All right, and we are all set, Senator.
Good afternoon, everyone. I am Jeb Bradley, Senate District 3. Today we're holding a meeting of the Senate Health and Human Services Committee. Before we get started, I'll read through a checklist to ensure that the meeting we are holding is in compliance with the right to know law. As chair of the Senate Health and Human Services Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12 pursuant to executive order 2020-04 and its extension, this public body is authorized to meet electronically. Please note there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that, number one, we're providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. We have provided public notice of the necessary information for accessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remote Senate, that's all one word, remote Senate at leg.state.nh.us, or you may call 603-271-6931. Number 4, in the event the public is unable to access the meeting, it will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done by roll call vote. And finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. I'll start the roll call with Senator Gray.
This is Senator Gray. I'm at my home in Rochester, and I'm alone in this room.
Senator Sherman.
Senator Tom Sherman. I am alone in the room in my house in Rye, New Hampshire.
Senator Whitley.
Hi there, this is Senator Becky Whitley, and in my home in Hopkinton. My family is in the house, but I am alone in the room.
And this is Jeb Bradley, and I am in my home in Wolfboro, and I am alone in the room. Senator Avard is not going to be able to be with us today, so it's just the 4 of us. So having completed the right to know script, I'm going to open the hearing on Senate Bill 59 and recognize Senator Sherman as the prime sponsor.
Thank you, Senator Bradley. This is Senator Tom Sherman. If I could take a 2-second sidebar. Jenny, Ken Norton is trying to get on to testify. Are you able to send him the Zoom link?
No problem, Senator.
Thank you. Where was I? Oh, so Senate Bill 59, relative to the collaborative care model service delivery method. This is in regards to psychiatry. This was brought to my attention by the Medical Society and specifically the Psychiatric Society of New Hampshire. And the idea of collaborative care is not a new one. It is one of the most efficient and effective ways to deliver care. And it's where your focus is on the primary care physician. And what you basically do is the primary care physician works in tandem collaboratively with a psychiatrist so that the patient has essentially one-stop shopping. And so the patient, the psychiatrist actually will have a chart on the patient They may never actually have a one-on-one with the patient unless it's felt to be necessary, but they are helping the primary care provider deliver the best care without the need for either the patient to travel or to have a separate consultation. So it's highly efficient. It's very effective. You can imagine the enhanced communication that it would involve. And in a state where we are all painfully aware of the workforce shortage and the workforce needs, especially in mental health, this is a really great way to extend the reach of our psychiatrists as broadly as possible, and so that they can see or be participating in as many patients' care as possible. So in terms of standard of practice, this would be completely acceptable, if not the best standard of practice in psychiatry. It also is much more cost effective, which is always important. In terms of the bill, we had a very productive meeting with the carriers this past week and the Medical Society and Dr. Ho from the Psychiatric Society. And so you will see there's an amendment there that makes it a little more straightforward. The major goal of the amendment was to pull out, if you look at the bill, let's see, it's section 1, Roman 1B. You'll see that it, rather than just depending on the Federal Register for the definition, it actually gives the definition of collaborative care. This bill was actually introduced by me last session. We had met with the carriers and they felt that we really didn't want to have the codes, which are the billing codes, in there because it's kind of locks you into those billing codes. So those were replaced with description of services so that if the billing codes change, we don't have to go back into statute and update those. So I think this is a really clean, effective, efficient way of incorporating this practice of collaborative care psychiatry into our repertoire. And I think we have some other people here to testify who can talk about their clinical experience with this and why it's so important. With that, I'm happy to take any questions.
Senator Whitley, question of Senator Sherman.
Thank you, Mr. Chair, and thank you for taking my question.
Of course.
So this model, does it require statute change because it's not being currently covered? Are there instances where it's not being covered currently?
Yes, and yes. So one of the reasons for statutory change is to make sure it's covered. And we did have the major carriers there, and they're all in support. The other is that one of the interesting things about this is that Dartmouth-Hitchcock is very keen on expanding this practice. But by putting it into statute, by making it available across the state, being sure that it will be reimbursed, it can be it's going to hopefully result in a culture shift in how we provide psychiatric care.
Thank you.
Further questions? Just one from me, Senator Sherman. Maybe you can outline how this model is more cost effective.
Yeah. Well, it's just the reimbursement. If you can save on a full psychiatry consultation, if you can shorten duration of disease, you're making a significant impact if you multiply that by the number of patients. So in a collaborative care model, the amount of time that the psychiatrist would have to spend with each patient is decreased. The reimbursement would be would go with that. And yet, as I mentioned before, communication and collaboration enhance the experience for the patient. So, we've seen this in many other specialties. When you provide appropriate care when it's needed, rather than letting it deteriorate, this is one of those things that we've talked about many times, Senator Bradley, where if we can decrease the preload on the emergency rooms and other emergency services, especially mental health, that's a win fiscally as well as from a patient standpoint.
Great. Further questions of Senator Sherman? Okay, seeing none. Thank you very
I
much.
think Senator Whitley had a question.
Oh, I'm sorry.
No problem, Mr. Chair, and thank you, Senator, for bringing this bill and taking an additional question. And maybe this is a question for other people, but I'm curious whether other states have allowed for coverage for this type of model and are actually seeing those cost savings.
They have allowed for coverage for this type of model. I'll let Dr. Ho talk about it because he taps into the National Psychiatry Association and he can talk more about standard of practice.
Excellent, thank you.
Okay, seeing no further question, Jenny, we'll let you call our next witness, please.
All right, first up, we have Dr. Patrick Ho. Dr. Ho, you should be able to mute yourself and we're ready for you to go.
Great. Can everybody hear me? Oh, excellent. Thank you. My name is Patrick Ho. I'm the current president of the New Hampshire Psychiatric Society. And I wanted to thank you today, Chairman and Senators, for giving me the time to speak about this bill. And of course, thank you to Dr. Sherman for bringing this bill forward. I fully support this bill because as a psychiatrist, I treat patients who not only struggle with mental health disorders, but also struggle to find mental health care due to the severe shortage of psychiatrists and other mental health practitioners in our state. So what I wanted to do today in my brief time was just give a little bit of the context in our own state, New Hampshire, and talk about where else this is being done in the country, to answer your question, Senator Whitley, and then also talk a little bit about the cost savings as well. So just to provide the background in our state, then although New Hampshire has one of the highest proportions of citizens suffering from mental health disorders out of any of the states, nearly a quarter of our citizens feel that their mental health care needs are unmet, which frankly is quite unconscionable. Collaborative care model services can help bridge the gap with better care coordination via integration of mental health and primary care. Collaborative care model services use a team approach consisting of a primary care provider, a care manager, and a psychiatric consultant. The team cares for a defined group of patients in that primary care practice and closely tracks each patient's progress. Treatment is adjusted if patients are not improving as expected, and patients who don't respond to treatment are referred to more intensive mental health specialty care, including seeing the psychiatrist. So instead of psychiatrists seeing all patients one-on-one, the psychiatrists provide caseload consultation to a population of patients for an entire primary care practice, providing proactive and effective care. This approach improves access, health outcomes, and reduces provider burnout. It's notable too that Medicare and federally qualified health centers already allow reimbursement for collaborative care model services. And this legislation would allow for primary care providers to bill commercial insurers for the model, which would safely increase access to mental health care. And as far as where else this is being done, then we have seen some success in states like North Carolina, Montana, New Jersey, Utah, and Washington State, which have each implemented similar statutes to allow for the billing of collaborative care model services. And also to speak to the savings, I think it helps to kind of conceptualize where we are as far as the mental health care services that we're able to provide in New Hampshire, because the cost savings are, as Dr. Sherman mentioned, really important to consider how we reduce the number of people needing more intensive mental health care needs, more intensive mental health care services, such as going to the emergency room or going to inpatient units like New Hampshire Hospital. And then when we consider the long wait lists and the boarding practices of the EDs in our states, where patients may wait for days to weeks for a bed at New Hampshire Hospital, then this can greatly reduce costs just by keeping patients out of the ED and keeping patients cared for in their primary care practices and their own communities. With the added stressors of COVID-19, I think the need for mental health care services is higher than ever, making the lack of access to these services even more pronounced and straining other healthcare resources like the emergency departments. So in my opinion, I believe it's now more important than ever that we allow for the use of evidence-based practices such as collaborative care model services to increase the availability of mental health services in our state. So thank you again for the time, and I'm glad to take any questions.
Are there questions of Dr. Ho? Senator Whitley.
Thank you, Mr. Chair, and thank you, Dr. Ho. So I heard you say that Medicare already provides this coverage. Does Medicaid in New Hampshire, does New Hampshire Medicaid provide coverage for this model?
New Hampshire Medicaid, I believe does, and this is different depending on where you are in the state because of the DSRIP, which provides a waiver for innovative services. And for instance, in the Dartmouth-Hitchcock, Lebanon region, then collaborative care model services are provided to Medicaid patients at Dartmouth-Hitchcock through DSRIP funding.
Thank you.
Dr. Ho, any comments on the amendment that Senator Sherman referenced? Because I think he said you had worked on it.
That's true, yes. And as far as comments on the amendment, no, I'm just very pleased to have come to an agreement with the major insurance carriers on the need for these services, and also just the fact that we need to provide better care for the patients in our state. So I was just very pleased to have that meeting.
Okay. Great. Seeing no further questions, Jenny.
All right, next up we have Tyler Brennan from the Insurance Department.
Good afternoon, Tyler.
Good afternoon. Sorry for the delay. It takes a moment before I get the chance to unmute myself. So Tyler Brennan, Director of Health Economics with the New Hampshire Insurance Department. And as most of you know, we don't have a position on the bill, and that's typically the case. And most of what I would have to say would just apply to mandates very generally, so not specific to this piece of legislation. I will say I've seen the language for the amendment, and that addresses some of the concern I had with the level of specifics in the bill. And this has to do with just procedure codes. Even if they're left off, the actual descriptions may get updated over time, and something that was considered 60 minutes in the past might be 65 minutes going forward. So to the extent you deal with those technical issues, the amendment, I think, does clean that up a bit. So mandates in general do tend to put inflationary pressure on premiums. They may save, new coverage may save money for particular patients, but when applied to the whole population, people tend to use those services more. And when you look at the pressure on premiums, there usually is an impact either through cost or utilization or some combination of the two. The other consideration, and this is potentially a bigger one in today's world, the ACA imposes federal requirements on states when they pass mandates that impact the cost of premiums. And this is because of the premium subsidies they pay in the individual market. So most people in the individual market getting their coverage through the exchange receive a premium subsidy. The federal government has said if states pass new mandates, the additional costs for those mandates have to be covered by the state. So far, this has not been an issue, but the federal government is coming out with a new template and some specific reporting instructions. So whether or not this particular legislation would qualify as a new mandate is a little bit unclear. But generally speaking, based on the guidance so far, a mandate that changes the scope of covered services would be subject to this reporting requirement and the state liability. I would add that the insurance department is in a position to evaluate new insurance mandates. RSA 400A39B gives us the authority based on the request of a particular legislative committee So if you wanted to actually analyze the legislation, provide an estimate of the impact on cost on premiums, we could do that through that statutory authority. Within that part of the statute, there's also the requirement to take a look at the social benefit and some of the other pieces that may go along with a particular mandate. So that's my testimony. I'm happy to take any questions there might be.
Senator Sherman.
Yeah, hey, Tyler, good to see you. Well, I guess I can't see you. So good to hear from you. This is kind of a catch-22. Are you saying that if a state says, say you've got X carrier and X carrier or carriers are not covering what is felt to be a state-of-the-art, cost-effective treatment, and the state says, well, you have to cover that treatment because it's state-of-the-art, it's cost-effective, that the state has to pay for that?
Well, I think you're raising an interesting question. What if the mandate resulted in lower costs overall? Well, since what a mandate typically does is put pressure on premiums, if you had a mandate that reduced costs, that would be a kind of a new situation that hasn't been really considered so far. So certainly to the extent that it doesn't increase costs, then there shouldn't be any state liability for it. But to the extent that there is a conclusion it does increase costs, then that's what we would have to pay for at the state level.
Follow up?
Further?
So suppose you had technology that's widely accepted, like cardiac catheterization for coronary occlusion, and the carriers just said, we're not going to pay for it. And the state said, well, that's ridiculous. So we're going to make you pay for it. We're going to make you cover that. Are you saying that the state can't, if they do that, then the state has to pay for that additional procedure and the carriers are off the hook? It would clearly increase the cost.
Yeah.
Because it's not a cheap procedure, but this doesn't make much sense to me if one of the state's roles is to ask carriers to do what is, most effective for their clients or their customers. But if the state mandates it, then the state has to pay for it.
If I understand your question correctly, if the carriers don't do something that you would think would be in their business interest, the state says you have to do it, then does that make sense? It triggers a liability for the state. I can only tell you what the federal requirements have been imposed, and I would say that based on the guidance so far, if the state passes a mandate, passes a new requirement for coverage of new services, then that's the trigger. And I wouldn't weigh in on whether or not that is a rational approach.
Well, it's just, I guess, one last follow-up. So this, just to clarify this thing you bring up, if I were a carrier, I would sell a policy that covered nothing and then sit back and wait for the state to force me to cover healthcare because that's the policy. And then the state has to pick up the liability for it. And I sit there making the profit on the policy I just sold that covers nothing. But I mean, is that what this does?
If I understand the question, which is okay, there are a set of mandates. There are both what the state mandates we have on the books, and included are some very interesting ones like obesity surgery. But regardless, we also have this federal overlay of essential health benefits. The essential health benefits are these 10 broad categories, but they also say, take a snapshot of something that took place, that was in place. And I think it was 2013, 14 that we said, okay, this is the plan design we're using. So what the federal government has said, any new mandates you add on from that point in time. So the product you would have sold with virtually no coverage wouldn't have met that set of mandates and set of requirements that has existed for a number of years. That being said, I'm not sure you'd have a lot of customers that'd be interested in the product. Doesn't cover anything, but
well, it'd be cheap.
It probably would be pretty cheap.
So let me ask sort of a follow-up question then. I remember setting those guidelines back as to what the typical policy was 7 or 8 years ago. And I'm trying to think of mandates that we have passed in New Hampshire subsequent to that, and I'm sure there are some, but we've never gotten a bill for it.
Yeah, so I think your question about what have we passed anything that that would have incurred liability based on the guidance so far? And I'm not, believe it or not, I'm not sure that we have. So I'm saying that optimistically, as I'm hoping it won't create a state.
Well, what about the audiology mandate and the autism mandate? Didn't they come after?
No, autism was before. And to the extent we're thinking about mandates, remember there's scope of services, and then there are things like cost sharing. So to the extent it creates a new set of scope of services that could be considered a mandate, then that could incur a liability. The federal government has been forthcoming in saying that they have not cracked down on this so far. But for the last year or so, we've been hearing about a new reporting requirement where they will be going after states, and we will have to report on new mandates that meet their very specific guidance, and we will have the liability.
Sounds like an issue for our federal delegation, but are there further questions of Mr. Brennan? Okay, seeing none. Tyler, if you could stay though, if we have more questions. Jenny, let's hear from one or more of the carriers.
It looks like all that we've got left to speak is the Medical Society. We've got Anthem. How about Anthem?
Yes, that'd be great.
Okay, so next up, we've got Sabrina Dunlap. Go ahead, Sabrina.
Hi, thank you. Happy to be here. So my name is Sabrina Dunlap. I'm Director of Government Relations at Anthem. And as Senator Sherman said, we had a great conversation about the bill, and we do support the amended version. On the conversation about mandates, I do just want to point out Anthem already covers these services, and I can't speak for everyone else, but I think I'd be surprised if other carriers didn't also cover the collaborative care model that we're discussing. And we've been ready to reimburse for it. It's just really a utilization issue. And so I think, as Senator Sherman mentioned, the hope is that the legislation will sort of encourage more use of this model, and hopefully providers will embrace it more. But just wanted to clarify that we do already cover these services. So anyway, I'm happy to take questions, but otherwise just wanted to thank Senator Sherman for engaging with us on this, and thank you for the changes. And again, we offer our support of the amendment.
So let me jump in right away. Thank you very much, Ms. Dunlap. So I think your testimony is that given the fact that you're ready to reimburse and these services are already covered, you would tell us this is not a new mandate.
Well, I don't want to overstep, but I mean, I think we as Anthem, yes, we would view this more of a directive. I mean, for us, it's really not a mandate because it's not expanding the scope of services or coverage.
All right, I'll take that as a yes.
I don't want to complicate issues for.
Yeah, no, and I appreciate that, but I mean, given what Mr. Brennan just said, and I appreciate the fact that you've worked with, Senator Sherman, because this is the right way to go. And it does seem as if it's not only better treatment, but, cost savings overall. We would not want to get flagged by, the feds, though, on sort of what I would consider a little bit arcane mandate from the feds back toward us. So that's all.
If I'm, oh, sorry.
Senator Sherman, go ahead.
No, I was just going to, I would just say, would you believe that one of the 10 benefits that Mr. Brennan was talking about is provision of mental health? So I think between Sabrina's testimony and the understanding that this is already one of the 10 components, I'd be floored if this were something that we get flagged on.
Okay, further questions of Ms. Dunlap?
would you believe?
Okay, thank you very much. So
Okay,
Jenny, the Medical Society.
all right. And we've got Mike Padmore.
Good afternoon. Thank you, Mr. Chairman and members of the committee. For the record, my name is Mike Padmore. I'm the Director of Advocacy with the New Hampshire Medical Society, representing physicians across the state. With respect to time, I was actually just planning to cede my time to Dr. Ho, who is the real expert on this issue. So I would just like to thank our colleagues from the insurance carriers for meeting with us this week to discuss this bill and find some common ground. I do think that we accomplished that with this amendment. So I'll just close by saying that the New Hampshire Medical Society supports the amendment for SB 59, and I'm happy to answer any questions that you might have.
Are there any questions of Mr. Padmore? Seeing none. Thank you very much. So I am just scrolling down through the list of attendees. I see somebody represent.
Sorry, Senator Jake Berry had signed up to testify as well.
Okay, go ahead.
And I also know that Ken Norton was considering testifying, and I think he may have just raised his hand.
Okay. Go ahead, Jake.
All right, sorry for the delay. All right, good afternoon, Mr. Chairman, honorable members of the committee. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for more than 20 years to address behavioral health issues in the state. I don't want to repeat too much of what's been said, but I do want to emphasize New Futures' strong support for this bill. In our collective work to address the ongoing mental health and addiction crises, we all speak often of removing barriers to treatment, eliminating silos, and increasing integration across the healthcare system. This bill would help us do exactly that. The collaborative care model, as supported in this legislation, more fully integrates behavioral health into primary care and helps to extend critical services to many patients where it's most accessible. The results are clear. The model has been shown to improve clinical outcomes and reduce treatment costs. I will be a great asset to our state as we continue to battle the ongoing addiction and mental health crises. So with that, I offer our full support and ask you to recommend this bill ought to pass. I'm happy to take questions.
Thank you very much, Jake. Seeing no, Senator Whitley, I'm sorry.
No problem. Thank you, Mr. Chair, and thank you, Jake, for your testimony. You raise an important issue with integration, and that's something that we talk a lot about as a goal in New Hampshire. And so I'm wondering what you think about how integration will contribute to those cost savings.
Oh, sure. I think that I think it was Senator Sherman who mentioned earlier that when you are able to have this kind of collaboration, you don't need to schedule separate appointments for for our psychiatrists or psychologists versus primary care. I think that, it just saves time, it saves money, it saves doctors' efforts, and it saves patients a lot of inconvenience in terms of having to go back and forth or log repeatedly onto Zoom. So I think that, just across the system, the more we can integrate and collaborate and so to save redundancies, I think that will certainly lead to cost savings.
Thank you.
Further questions? Okay, thank you very much, Jake. Ken? Good afternoon, Ken.
Good afternoon, Mr. Chairman, members of the committee. I'll be very brief given time. Ken Norton, Executive Director of NAMI New Hampshire, the National Alliance on Mental Illness, and would just support everything that's been said previously by Dr. Ho, Senator Sherman, and others. I would just add the importance of this bill right now. Dr. Ho mentioned COVID, but I would also mention that this past week we've exceeded the number of adults and children being boarded in emergency rooms, previous record, into the 80s now at times. And any steps that we can take to address mental health and substance misuse as the important public health issues that they are, including suicide prevention. And on more than one occasion, I have had a primary care provider said to me that the lack of integration in services, they felt had they had more integrated services, they may have been able to save somebody's life. So With that, I would just say that NAMI New Hampshire strongly supports this bill and ask you to vote it as ought to pass.
Okay, any questions of Mr. Norton? Thank you very much. Anyone else?
I don't see any hands up, Senator.
If there is anyone who hasn't testified for a first time, if you could raise your hand so Jenny can see you, that would be great. Going once. Going twice. In that case, I am going to close the hearing on Senate Bill 59, and we'll open the hearing on Senate Bill 74, and again recognize the prime sponsor, Senator Sherman.
Senator, you're muted.
Yeah, I got it. Thanks. Thank you. I was just starting to talk. Thank you, Mr. Chair. For the record, Tom Sherman, Senate District 24, which is 11 towns on the seacoast. And I am introducing, this is 78, right?
74.
I knew there was a different number. So this is Senate Bill 74, which is dealing with advanced directives, end-of-life care. I am doing this at the request of a group of stakeholders who have been working for a year on updating our statute. And I will defer to Paula Minahan and Kate Hanna if she's going to be speaking, but at least Paula to talk about the specifics of the bill. What I will add, though, is that we have a commitment that we've made working with Senator Bradley and with all the stakeholders, including the elder law folks and the Disability Rights Center, that we will be convening a working group to try to iron out any concerns that may persist in spite of all the efforts that people have made. And so we have met with all the stakeholders. I think bringing everybody together is the way to go, and having a working session to make sure everybody's comfortable with the final result. So with that, I will end my testimony. Happy to take any questions, but this is a work in progress.
Okay, are there any questions of Senator Sherman? All right, so what I would say for everybody that wants to testify, I think given the fact that Senator Sherman and I have talked about this, that he's going to convene a working group. We don't have to go into every nuance of the legislation this afternoon. If you could, just think about that as you testify, that would be helpful to all of us. Okay. So Jenny, why don't we recognize Paula Minahan next?
Okay.
And she may want to testify. Well, let's just do one at a time.
Okay.
Good afternoon, Chairman, members of the committee. Can you hear me?
Yep.
Okay, great. For the record, Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our state's community as well as specialty hospitals. The Hospital Association is in strong support of Senate Bill 74, and I do want to thank Senator Sherman as the sponsor of this legislation, as well as co-sponsors to include Senators Bradley and Whitley. I just will spend a little bit of time with the background on the Healthcare Decisions Coalition that Senator Sherman mentioned, and why they believe that the statute and the bill before you was needed. And it was a result, as he said, of many months of thoughtful work by members of this coalition, some of whom will be testifying today. And they are experts in their various professions of palliative care medicine, healthcare law, and others that care for patients at their most vulnerable state. We also, with me today is my colleague, Brian Kugel, who will works for the foundation and is the chair of the coalition, the Healthcare Decisions Coalitions. And I will ask him if he could speak, if you would oblige after, to have Brian speak for a few minutes, because I think it would be helpful to just give you some context, because the stakeholder group is really, critical to how this all came to be. I did submit some written testimony in to be respectful of your time and to the point that you both made, that we will be having a working group. I will not go over all the changes to the statute. You will see them in my testimony. I outlined what the goals were to honestly, to try to make this easier for people to use, and to just make it more clear. And that really truly was our goal. In addition, you will see some changes to the statute to incorporate gender neutral terminology, which Senator Sherman rightfully outlined early on that needed to be done. And I think we achieved that by incorporating this. I also, as Senator Bradley and Sherman indicated, we have tried to reach out to many stakeholders, but we were not able to connect with everyone. And I do appreciate and welcome the work group that Senator Sherman is going to convene. I think it's a really good idea. We need everyone's input. I think we're all, want to achieve the same result, and I look forward to that. I do want to make clear, though, before I finish, that we did not attempt to change longstanding policy relative to this statute, which has been on the books for a long time. And as Senator Sherman said to me and to us when he agreed to sponsor, he does not want to weaken the statute. We just want to make sure it's easier for patients and their loved ones to understand the forms that are needed to complete and properly express their wishes for the providers that care for these patients, and again, to respect their wishes. So we are in strong support, and if you would oblige, Chairman Bradley, I would like to ask my colleague Brian Kugel to speak for a few minutes about specifically the Healthcare Decisions Coalition. Thank you.
Thank you very much, Paula. Are there questions of Paula? So I just have one, Paula. Could you just outline what those longstanding policy decisions that have been made in the past are, just so the committee is aware of what they are and what we are hopefully not changing?
If you would, Senator Bradley, others on the call, in the hearing, I think will be better to outline those, if that's okay. Thank you.
Okay, great. All right, so Jenny, why don't we recognize, I didn't write his last name down, I apologize, but Brian.
Brian Kugel.
Thank you, Senator. Thank you, Mr. Chair. Thank you, Senators, for your attention. I'm Brian Kugel. Can you hear me okay, Senator?
Yeah.
Thank you. I chair the coalition, which is the Healthcare Decisions Coalition. I have served on the coalition for over 15 years, over 20 years, and I have began my activity with this coalition while working in the long-term care sector at Havenwood in Concord. The purpose, it was set up originally to support a grant whose purpose was to promote advanced care planning and to work on ways in which patients could express their preferences to guide healthcare professionals for end-of-life care. So the long-standing statutes have promoted techniques and methods such as advanced directives in which a patient can direct the medical establishment, the medical system, to act differently if that's what they want at end of life. So the coalition and the Foundation for Healthy Communities consists of people in several sectors, some people from elder care law, some people from special populations, many people in the healthcare sector. We interest ourselves in publishing guides and publishing the actual form so that consumers can complete advanced directives at no or at no cost to themselves. We also concern ourselves with training healthcare professionals to understand what the law is, what the rules are, and to develop the skills to help people consider putting in their own voice what they want and don't want for care at the end of life. Out of these efforts along over these years have come other devices such as the portable DNR order and medical surrogacy. What you have before you is a bill that speaks to many, it's what would seem like miscellaneous changes, but they are minor but important changes that have affected people where the bill as it exists is confusing or hard to interpret. And because that happens, people aren't able to get what the bill intends and what the coalition intends. And I think what all good medical practitioners intend, which is for their wishes to be carried out, even when they are not able to express their wishes. So with that, I will stop my testimony. You have some written testimony from me and allow other people, but I will answer any questions you might have about the coalition, its work, and the things that it's paid attention to.
Questions of Mr. Kugel?
Senator Whitley, thank you.
Senator Whitley.
Thank you, Mr. Chair, and thank you for taking my question, Mr. Kugel. So I think it's important that, and I actually speak as a family member of an individual with disability, I think it really is important to include, people who are impacted or potentially impacted by even minor changes in this statute to be part of this coalition. So I'm just wanted to confirm that you will be reaching out to folks who in the disability rights community, but also individuals who might, to patients that might be impacted by this statute.
Absolutely, and thank you for your question, Senator. Over the span of time that I've been involved with this coalition, disability rights community has been active and inactive in its ongoing work. And that's true of many, many different types of people in the coalition. You're not required to be at every meeting. But what's been really important is that our teaching with regard to people's use of these forms and the guidance that's offered speaks to helping special populations with special considerations. The ultimate goal is that what works for you does not work for me, and we want a system that works for every individual on the basis of what they want. So thank you, Senator.
Thank you.
Further questions? Okay, seeing none. Jenny.
Next up, we have Kate Hanna.
Good afternoon. Thank you, Mr. Chairman and the committee. My name is Kate Hanna, and I wish to speak in favor of Senate Bill 74. I'm a New Hampshire lawyer who's been practicing in the healthcare field for 40 years. During those years, I've served as counsel to hospitals, nursing homes, hospice groups, physicians, and nurses. I frequently advise them on difficult questions regarding the interpretations of advanced directives. As such, over the years, I've gained an appreciation for many of the questions and ambiguities that arise for healthcare providers and New Hampshire citizens when faced with conflicting or ambiguous advanced directives. I'm speaking to you today not on behalf of any interest group, but rather as a volunteer who's worked for years to create an effective format for our fellow citizens to express their healthcare wishes in a manner that will be honored and carried out with integrity by our healthcare providers. Before I proceed, I'd also note that before I went to law school, I served as a member of the New Hampshire House back in 1975. So I have a great appreciation for how difficult it is for all of you to create legislation that meets everyone's needs. First, I want to briefly, and I mean very briefly, review the history of advanced directives in this state. And this, I think, goes to Senator Bradley's question about what are the fundamental issues that have guided the state over the years that we want to leave intact. In 1986, the living will legislation was passed. That allowed every citizen to execute a document that articulates his or her end of life wishes. The living will is self-executing, and healthcare providers are required to heed the person's end of life wishes. In 1991, the Durable Power of Attorney for Healthcare legislation was passed. This document was not just aimed at end of life decisions. The Durable Power of Healthcare document allows anyone 18 years or older to appoint a trusted person to make healthcare decisions for them should they become incapacitated. And those decisions are made in real time under then existing circumstances once one is deemed incapacitated. In 2015, it had become apparent that despite active measures by the state to encourage people to execute advance directives, less than 50% of our population had done so. That's what led to the surrogacy laws. And that is that if someone had failed to appoint an agent under a durable power document and was then deemed incapacitated to make her own healthcare decisions, the person's healthcare practitioner was charged with selecting a surrogate decision maker from a prescribed hierarchy of family members or close friends who could step in to make the decisions, the same decisions that an agent under a durable power document could make. One of the main reasons for this legislation, the surrogacy legislation, was that the legislature wanted to save families of a patient who had not executed a durable power document and appointed an agent from being required to seek a probate court guardianship, a process that can cost more than $1,000 and take many weeks. As Senator Sherman stated, Senate Bill 75 seeks to clarify and not weaken all of the foregoing principles that have stood the test of time in New Hampshire. Above all, the bill underscores that at all times, and I think this is key, an agent or surrogate must act in accordance with the person's wishes and religious and moral beliefs as stated by the person orally or in writing, including in their living will. Senate Bill 75 recognizes that these legal documents must be written in a straightforward and simple manner so as to allow those who may not have access to lawyers, and that's maybe the majority of those who complete these documents, to be able to complete the forms without expense and with the knowledge that they understand what the document means. In short, the bill seeks to eliminate language that we have learned over time the average person does not understand, and for good reason, since the language in the current statute can be extremely confusing. I'll give you just 3 short examples. First, many people do not understand how their living will fits with their durable power of attorney for healthcare document. Current law states that if there's an inconsistency between the 2 documents, the durable power document supersedes, because through it, the principal has selected an agent who can make decisions, as I said, in real time under then existing circumstances. This bill does not change the current law in that respect, but simply highlights the importance that a person consider executing both documents. Second, the bill removes the incredibly confusing language that previously required a principal, the person executing the document, to take affirmative steps to clarify that even if she becomes incapacitated, she still wants her agent to make healthcare decisions for her and to be able to override her on any healthcare decisions. I find that most people, when executing the durable power document, are totally confused by this provision, asking, isn't that exactly why I'm completing this advance directive in the first place? To allow my agent to speak for me if I am deemed by my physician to be incapacitated to make my own decisions. In short, the bill reverses the presumption in the current statute that the principal would always want to be able to override his agent's decision-making, even if the principal is incapacitated. And by the way, that doesn't mean that someone can state the opposite in his or her advance directive. It just means that there's no longer that presumption. Finally, this bill eliminates the 90-day tenure of a surrogate's appointment. As mentioned above, many of the main reasons of the surrogacy law was to save families the expense and agony of seeking a guardianship over their loved one in every instance where the person had failed to execute an advance directive, which, as I said above, is about 50% of the time. Under the current law, on day 91 of a surrogacy, even if the family in principle is totally satisfied with the particular person who is appointed surrogate, the surrogacy abruptly ends and the family is forced to seek a guardianship in the New Hampshire probate court. It seemed more reasonable to allow the surrogacy to continue unless the family chooses to seek a guardianship in probate court. And by the way, under both current law and under this bill, any person who questions the appropriateness of an appointed surrogate or an agent can seek a guardianship in probate court at any time. In conclusion, I believe that SB 74 clarifies many previously ambiguous portions of these advance directives, and I hope you'll support the bill. I'm happy to answer any questions.
Are there questions of Attorney Hannah? Seeing none. And we have your written testimony, is that correct? Okay, thank you. Okay, Jenny, you're muted.
Next up, we have former Senator Matt Hood.
Good afternoon, Matt.
Greetings, Mr. Chairman, members of the committee. I heard the message about the work session on Tuesday, and I have submitted written testimony, which I will not read, so I will try to be brief. But I did want to take a moment to speak to, for the record, Matthew Hood, Vice President of Government Relations at Dartmouth-Hitchcock. I'm testifying in support of Senate Bill 74, and the two components that I wanted to speak of, one general and one particular. The general is expressing on behalf of the Honoring Care Decisions program within Dartmouth Centers for Health and Aging, which has prioritized making the advanced directive forms more user-friendly. Wanted to support the bill because the changes significantly advance that effort. So that's in a very general sense. And then in a more particular sense, and Senator Bradley, to your point, I will speak to this, but I actually think this is a change in policy that's being proposed here. As many on this committee will remember, last year, there was an issue that came up in the context of preclusion in statute of an agent consenting to experimental treatments. And the problem that generated as COVID hit was that there were some experimental treatments out there that patients were incapable of providing consent for, either because they were unconscious or intubated or any other reason. Recognizing this, Governor Sununu issued an executive order allowing for an agent to consent in that situation for a patient who was suffering severe COVID symptoms. And this committee took the lead, thank you, in codifying that permissive, the agent consent in that situation. However, that provision is set to sunset July 1, I believe, of 2021, and it only pertains to COVID. So what the amendment, one component of the amendment that you have before you today would do is essentially strike the preclusion of an agent consenting to an experimental treatment and instead allow an agent to consent to clinical trials or experimental treatments, provided the treatment protocol and the IRB, the Internal Review Board, engaged, complied with all federal regulations and laws in that context. So I at least wanted to point out to you not what was a long-standing consistency, but something that would change direction, expanding upon what we did for COVID and making that available in other unknowable situations in the future. So I'll pause there and say this. which is I'm happy to answer any questions that the committee may have. What might make more sense, however, is to have the attorney who assisted with this drafting and this concept and/or an IRB representative join the work group on Tuesday, if that would be amenable to the committee. Thank you very much.
All right, thank you, Senator Hood. Are there any questions? And I think rest assured, Senator Sherman will invite you.
I'm feeling very welcome. Thank you.
Yes. First of all, Senator Hood, if you wouldn't mind just getting any contact information over to Jenny so she can make sure they're on the invite list. And isn't it correct that prior to understanding that we were allowing consent for, I can't remember the exact term, but basically being able to do studies, especially with COVID, because I recall in Nashua and up at Dartmouth Hitchcock, there were studies that people did not have access to, but that they were felt that they may be life-saving in those settings, especially in the setting of COVID. You can get permission, but it requires that you have to go through the court system to do so, which the concern was that that would, not just with COVID, but I think this is why we're talking about allowing this to move forward within statute and more broadly, is that it would be that process of having to go to court can actually delay onset of the experimental protocol and potentially put a patient at risk because they just can't get into the study in time. Is that not correct that they can do it, but it would require a court order?
Thank you for the question, Senator Sherman. And I would defer to either Attorney Hannah or certainly the folks in our legal department to answer that question, but it is absolutely a significant matter of timing in many of these situations. And if you go to court, notwithstanding the court's valiant efforts to expedite matters in these situations, that process alone could take very valuable life maintaining time.
Further questions of Senator Hood? Okay, seeing none. Go ahead, Jenny.
Next up is Colleen McCormick.
Good afternoon, Mr. Chair and Senators. I have a couple of items that I'd like to bring to your attention from my reading of Bill S-74. A little bit about my background. I'm a nurse practitioner, a nurse of 50 years, and I also have a second graduate degree in bioethics. And I have taught medical ethics at the University of Vermont. I have been on the ethics advisory committees at the University of Vermont, at the VA in Manchester, at the Elliott Hospital, at Northeastern Regional Hospital in Vermont. Served on those and also served on the Institutional Ethics Advisory Board at the University of Vermont at the Fletcher Allen. So in my reading of this bill, there are a couple of items that give me concern. One is that a surrogate who has been designated not by the individual in question can override the previous existing living will or for the patient. And previously, that was not, I believe, the case for the principal, that a surrogate who has been identified apart from, not by the principal, but by someone else. And although I think we like to believe that things are always done according to Hoyle, I'm not sure that that always happens. The second major concern to me is all the content inviting withholding, nourishment, and hydration on people. And it frequently says that it's not supposed to hasten their demise. However, that's the only thing withholding nutrition and hydration can do, is hasten somebody's demise. If you are dying, it will not keep you alive. But if you are living, withholding nutrition and hydration will definitely cause your demise. So I think that that is something that needs to be go under careful consideration and should not be part of, is frequently mentioned in this bill on withholding nutrition and hydration. IVs are minimally invasive, and they actually can be considered comfort care, because if you are dehydrated, you may have dry lips, but what you'll have is what's called a parched throat. If you do not get sugar, you will have a tremendous headaches. If you do not get electrolytes, your body muscles go into spasm. If anybody's ever had a Charlie horse, you know that. So really part of comfort care would be provision of hydration and electrolytes for the patient. Also, the designation of people as permanently unconscious is and unable to communicate, permanently unconscious and unable to communicate. If you can't communicate your thoughts and awareness, that doesn't mean that they are absent. It means you can't communicate them. Nobody can really assess that you are not thinking or aware if you cannot communicate it. So unconsciousness is not always permanent. There is a syndrome called locked-in syndrome. We actually have a rather famous woman from New Hampshire who suffered it for many years called Victoria Arlen. People go into locked-in syndrome and they come out again. But if they're dehydrated and starve to death in the interim, they don't come back out again. It is a very real syndrome. One of the problems is that we understand it poorly. And unfortunately, in healthcare, when we understand something poorly, it makes us very uncomfortable. And we sometimes seek a solution to the problem that's not necessarily in the best interest of the principal. I think that it's very onerous, these kinds of legislation. And I'm not saying that a lot of the content of this bill isn't good. I do think it is. I'm particularly disturbed about the part of withholding nutrition and hydration, but I think that it is onerous in that historically, physicians kind of self-monitored and decided what was acceptable practice, what was the standard of care, et cetera. Since in recent decades, as legislations have gotten involved, instead of physicians leading decision-making, frequently bodies of physicians start to make their decisions based on legislative action. So for instance, in 2019, the American Association of Family Practice Physicians established neutral language on physician-assisted suicide or physician-assisted death. And one of their rationales behind doing that was that they were trying to cover those members who worked in states where those things were legally acceptable. So now, rather than the physician group, the people with the most expertise kind of leading the way, we're kind of following, in many cases, people are starting to follow legislative activity. And legislative activity often can be in response to a few very vocal people who have sometimes motives that are a little bit different than the general population of physicians and nurse practitioners, but they are vocal, they are very active, etc. So they can sometimes foment changes in legislation that actually end up dragging the profession as a whole down a different road than many practitioners want to go. But I know that a lot, especially when it comes to things like nutrition and hydration, a lot of people think that it's a kind of a modern response to the current vagaries of healthcare, that we have many people who are who probably who might not have be living except for modern healthcare. But it's very important to know that the Hippocratic Oath, which until the 1980s was for millennia was the accepted standard of care for people. Margaret Mead, I want to close with a quote, and I will send you, I'll send you a more organized testimony. I've only actually known about this hearing for about a day and a half, but I will send that to you. But Margaret Mead once quoted, with the Greeks, the distinction was made clear. One profession were to be dedicated completely to life under all circumstances, regardless of rank, age, or intellect, the life of a slave, the life of the emperor, the life of a foreign man, the life of a defective child. But society is always attempting to make the physician into a killer, to kill the defective child at birth, to leave the sleeping pills beside the bed of the cancer patient. That was Margaret Mead. She was hardly what anybody would call a conservative thinker. And a quote to a psychiatrist in New York. So I just want to say that we have to be very cautious. I think it's particularly about nutrition, hydration. I think particularly in the face of syndromes and diseases that we have very little knowledge of, the fact that somebody may be in prolonged state of unconsciousness does not mean that they are dead or dying. But if you withdraw nutrition and hydration, it certainly does. That's certainly going to be the outcome. I do think that vulnerable populations are made more vulnerable when nutrition and hydration is these things are withheld. We have to be careful of that. A social worker in the early 2000s published an article where she did a study and found out that people who are on Medicaid were more likely to have a DNR order than the rest of the population. So we have to be consistently thinking of those vulnerable people who may not have a voice for themselves, and if a surrogate is designated who can override wishes, I think that can be a particularly dangerous path to tread. And I'll close with that. Thank you for your time.
Okay, thank you very much. I think you should make sure that Jenny has your contact information so that Senator Sherman can include you in his work.
I will. Thank you.
Senator Sherman, you're muted.
Got it. I was just going to ask Colleen, where do you live in New Hampshire?
Manchester.
Oh, okay, good. And I'm sorry, I must have missed this. Who do you represent?
Oh, I'm just an ethicist, just a medical ethicist.
Okay, I just didn't know if you knew. I'm also a physician.
Okay.
So I didn't know if you were aware of that. But would you believe there are ways to determine brainwave activity without actually being able to talk to people, such as EEGs and others that are very well accepted and standard of practice for determining brainwave activity. So I think you bring up some interesting points, and we certainly can consider those. Thank you.
Can I share an anecdote with you?
I think we still have a number of people waiting to testify, so please, briefly.
Okay. 15-year-old girl in the ICU after a motor vehicle accident for quite a long period of time. Negative carotid artery studies, negative EEG. The transplant team went to her family repeatedly, this was at the University of Vermont, repeatedly requesting that she be a candidate for organ transplant. Her family refused, That young lady eventually walked out of the University of Vermont hospital under her own power. So yes, we have studies, yes, we have tests, yes, we rely on them. They may not always be as accurate as we would like to believe.
Okay, thank you very much. Jenny?
Next up, we have Gina Balkas.
Go ahead, Gina. How are you?
Good afternoon, Mr. Chairman and members of the committee. I'm Gina Balkas with the Granite State Home Health and Hospice Association, representing home care, hospice, and palliative care providers throughout New Hampshire and the patients they serve. I did submit written testimony, so I'm just going to quickly summarize a few key bullet points. First, our association members care for individuals from birth through end of life, primarily in patients' homes. And we do support Senate Bill 74. This bill, the policy that the state has had is assuring that an individual's wishes are honored at end of life when the person may be unable to articulate their own wishes. It really is the core of the legislation that that late Senator Susan McLean championed in the late 80s and early 90s when the laws were enacted. And it remains the core of Senate Bill 74 introduced today. We believe that this bill improves New Hampshire's advanced directive laws by clarifying definitions and simplifying much of the legalese in the existing form. It also makes it easier for healthcare providers to honor patients' wishes without having to seek legal counsel or judicial orders. And it will allow for smoother handoffs between providers, allowing medical orders to follow the patient across the continuum of care. So one major change, one major improvement is on page 14 of the bill. This is the disclosure statement, which must accompany the durable power of attorney document. And it has been revised from lengthy legal jargon to concise, simple language. I want to point out that it covers all the same points that an individual should know prior to signing a durable power of attorney for healthcare, but it's just in much simpler language. Another improvement, it relates to surrogacy. So there is some confusion as to whether the surrogate has the same authority as an appointed agent. Some legal counsels have advised that a surrogate, such as a wife, a husband, or adult child, may not be able to consent to withholding or withdrawal of life-sustaining treatment because New Hampshire's existing law only allows an agent to do that with express written permission in an advance directive. But here's the catch-22. A person becomes a surrogate because there is no written advance directive. And so Senate Bill 74 eliminates the requirement that an individual expressly permit in writing the withholding or withdrawal of life-sustaining treatment. And this section has been a cause of great confusion for agents, for providers, and especially for family members who are surrogate decision makers. And then lastly, recognizing DNR orders and PULSE and their counterparts from other states means that practitioner orders for life-sustaining treatment can accompany a patient in whatever setting they may be, a hospital, a nursing home, or at home with a home care or hospice provider. And this is so important in honoring an individual's wishes across the continuum of care regarding the treatments that they desire or that they decline. And it's really become vital during COVID-19 when many people are choosing to receive care in the community or in their homes rather than in hospitals or nursing homes. So on behalf of our hospice, home care, and palliative care providers and the patients we serve, I ask that you recommend Senate Bill 74 as ought to pass. And our association is very happy to participate in any work group to refine Senate Bill 74. Thank you for the opportunity to speak.
Thank you very much, Gina. Are there questions of Ms. Balkus? Okay, Jenny?
Next up, we have Phil Lawson.
Good afternoon, Phil.
Hey, Senator Bradley, Phil Lawson here. I'm a physician who's been practicing in New Hampshire now for more than a couple decades in a bunch of different roles as a family physician at a community health center, as an emergency room physician, and as a palliative care consultant. So I've had the opportunity to see the impact of the present law, RSA 137J, at many points of the trajectory of patients' care. And unfortunately, I've seen some of the barriers and issues that have arisen associated with the law as written. And I wanted to just touch on a couple of those briefly. The first, which from Ms. McCormick's testimony sounds like it may be a more of a kind of hot button issue, is this issue of medically administered hydration and nutrition. The law as it stands stipulates 3 very limited and very specific circumstances when a feeding tube or an IV for fluid would not be legally expected to be administered. That suggests that essentially every frail elderly person who's not eating enough or not drinking enough and not able to state what they want requires a feeding tube and an IV for hydration. This is not consistent with the values and the goals of a significant percentage of patients who I care for, and as well, really with general standard of care. Everybody should have the opportunity for that form, like other forms of life-sustaining treatment, absolutely. But the law should not force these interventions upon patients when their advocates, agents, or surrogates do not find it in their best interest or inconsistent with their values and goals. And so SB 74 attempts to clarify that by giving people the opportunity to state more clearly in what circumstances they would want medically administered hydration and nutrition and other forms of life-sustaining treatment, and gives their agent the authority to do that and to follow those wishes. The second kind of challenging area is, as Kate referred to, is the treatment against objection clause. And that's very unique to New Hampshire. None of my colleagues or myself has experienced this in any other jurisdiction that we've worked, that you have to previously state very specifically that your agent can treat you if you object after you have lost capacity, or else you will not be treated. Let me give you an example. Just this week, an 84-year-old after surgery was delirious and in pain in our hospital, but showing signs of objecting to treatment, pushing the nurses away, pulling at his IVs. We are not legally able to treat that patient against his objective, despite an activated agent, because he did not fill out that section of his advance directive. This was to his wife's horror. We encounter these challenges frequently, and we certainly believe strongly that people should have the opportunity to state that they don't want treatment against objection, but making it the default if someone has not previously stated sets up a huge percentage of our patients we care for an inability to treat them if they show any signs of objection after loss of capacity. And then finally, I just wanted to like Gina said, further promote the codification of the POST and DNR forms. As an emergency room doc, these are incredibly valuable instruments that allow us to target treatment to the goals and values of the individual moving forward, right from the moment they arrive in our emergency department. These frequent, frail elderly people coming from nursing homes with very little information. And placing those forms have been indispensable in us providing the best quality of care that's targeted to the goals and values of each individual. In my palliative care work, I care for people, through the end of life significantly. And I just want to say, we only die once. We only have one opportunity to do this well, to honor the values and the goals of each individual person in the state that we care for. And this is incredibly important law, and I really strongly favor the changes of SB 74 and are in support of it, and commend you and thank you, senators, for your work on it. I'd be happy to answer any questions now or later, and I've sent my contact information with my submitted testimony.
Okay, are there questions for Dr. Lawson? Thank you very much.
Next up is Heidi Kroll.
Good afternoon, Chairman Bradley and members of the committee. Can you hear me okay?
We can.
Great, thank you. Good afternoon, Mr. Chairman and members of the committee. Thank you for the opportunity to testify before you today in opposition to SB 74. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan and Gartrell, and I'm here today on behalf of the New Hampshire chapter of the National Academy of Elder Law Attorneys, otherwise known as NALA. By way of background, NALA was founded in 1987 as a professional association of public and private sector attorneys, judges, law professors, and law students who are dedicated to improving the quality of legal services provided to seniors and people with special needs. The New Hampshire chapter of NALA was founded in 2005 and now has approximately 100 attorney members who represent thousands of New Hampshire elders and their families, many of whom are of modest means. Some members of New Hampshire NALA also represent nursing homes. NALA members assist their clients with public benefits, probate and trust administration, guardianship, health and long-term care planning, and estate planning, among other issues. As I mentioned, New Hampshire NALA is opposed to SB 74. And there are a couple of other attorneys who I think will, who are NALA members who will testify here today. But the bill raises many serious questions, concerns, and potential unintended consequences. The big picture is that this bill reverses default assumptions about the rights of patients. It shifts the balance of power away from patients to their agent or surrogate in ways that may have unintended consequences. And it alters our current system of checks and balances, including use of the courts, which serve as an important purpose, namely to protect a patient's rights and wishes. So in short, SB 74 will have significant consequences in terms of people's rights, wishes, and autonomy. And we just feel that we need to be very careful in making any changes. The issues raised in this bill are very complex and really, frankly, too important to be rushed. They deserve careful consideration through an inclusive stakeholder process, which to our understanding has not taken place yet. I did reach out to a wide variety of different groups who I thought might be involved in this, and none that I reached were in terms of this coalition that worked on the draft. So we greatly appreciate Senator Sherman's and Senator Bradley's willingness and others on the committee willingness to convene the interested stakeholders. For the moment, we would respectfully request that this committee vote to re-refer this bill so that there can be adequate time for a careful and thorough stakeholder dialogue about the significant changes that are proposed in this bill. And New Hampshire NALA would welcome the opportunity. We are ready and willing to work with this committee and interested stakeholders in that process. So I thank you very much for your time, and I would be happy to answer any questions.
Seeing no questions, since you're going to participate in the work group, I hope that's sufficient. Is
yes.
that okay, Senator Sherman? Or do you have a question?
I was just going to bring up Heidi, I'm a little surprised, and my question was, I thought we had agreed that we were going to work in the work group on this. So I hope you will come in with an open mind.
Absolutely. And I think the question is just how much time, and certainly if there's a sense that we could bring all the stakeholders together and reach a consensus in a shorter time, then re-refer would not be required. So absolutely, we're more than willing. We're very interested in participating in the process and going through the bill very carefully and understanding the goals and objectives of everyone around the table, and hopefully reaching compromises as we did during the surrogacy, when we amended the surrogacy laws. We were a part of that. That was a very long and careful process, but at the end of the day, I think everybody made concessions and understood where things landed and were comfortable with where things landed. So I think we're hoping for a similar sort of process. So absolutely, we look forward to working with this committee on that.
Thank you.
Okay, seeing no further questions, Jenny.
Next up is Benjamin Syracusa Hillman.
All right, and he was one of the attorneys I think Heidi referred to. So I'm hoping people will, if they're being repetitive, at least be fairly short. Thank you.
Thank you, Senator Bradley and the committee. I'm Ben Syracusa Hillman. I'm an attorney at Shaheen and Gordon. I practice in Concord and Dover primarily, and I am a past president of the New Hampshire chapter of NALA. Senator Bradley, I do appreciate the goal of keeping the hearing non-repetitive and also having the opportunity to work in the work group. I will keep my comments brief. Obviously we've heard from a number of folks who are promoting the bill, and so I do think it is important to for the legislative record to have other perspectives, but certainly in terms of the details and the substance, I'm hopeful we can work together. Personally in my practice, it's a mix of estate planning and probate litigation. I do guardianship work as well as work with clients who are doing their planning, including, signing of advance directives. So I'm intimately familiar with the current form. And I agree that it's a flawed form. There is room in a flawed statute. There's definitely room for improvement. I don't think I disagree with most of the things that Dr. Lawson and others said in terms of the barriers that that parts of this statute provide, and I would be very interested in working on a process to revise it. I think we just have concerns. Our group has concerns that important stakeholders who have been integral parts of these processes in the past were not part of the coalition that prepared the bill. I understand that it was a full year of process to work through these details. And unfortunately, there were just a number of stakeholders, and I'm not ascribing any ill intention on anyone's part, but unfortunately, a number of stakeholders were left out of that process. And so we've sort of been trying to scramble over the last week to kind of understand and establish our concerns, but our membership is diverse. People have different perspectives, and even in articulating specific concerns, I'm not necessarily speaking on behalf of our group's membership, but at least to identify some concerns. One thing I'd say overall is to get to the substance. So the bill, and I'm just going to touch on a few things. The bill, in terms of the form it produces, goes in a very different direction than the national trend. I mean, the national trend is towards more specific provisions in advance directives, particularly surrounding various stages of dementia and decisions that individuals might want to make under various circumstances. And I think there are pluses and minuses to that approach. Our membership certainly is not, of one voice on whether that's a good or bad idea, but I just thought it was worth noting that this bill's sort of elimination of individual choice in the form is definitely contrary to the national trend. Now, I appreciate that the language of the bill, the law itself still allows individuals to do to make any choices that they want by filling in the additional instructions lines. But I think the reality is whether an individual is signing this in the hospital with a social worker, or their provider, in a lawyer's office with a lawyer, or most often probably at home without anyone assisting them, they don't read the instructional statements a lot of the time. They don't necessarily have a full understanding of all of the implications. Most people are obviously not reading the statute, but having the presence of questions in the form both serves as an educational tool for the person assisting or the person who's self-educating and force decision-making. And these can be difficult issues and questions and deserve careful thought. And I've had many clients who have wanted to engage in very extensive conversations about various questions in the advance directive and what they mean and what the implications are. And I always encourage them to, also have that conversation with their primary care provider as well. But for people who are trying to be thoughtful about this, I think the questions in the form prompt that thinking, and the elimination of those questions, I fear would eliminate that process for a lot of people. Again, not to say that there's not a lot of room to reword and make them more clear. And I would just, call the committee's attention on that front to some of the research that we've seen come out on behavioral psychology. There's been a lot, for example, in the context where, people are signing up for their 401k plan at work. If they're signed up automatically, they're much more likely to participate. If they have to sign up manually, they're not. And so there's, when you have choices that someone is forced to make in a process, they have to make them, and just assuming that they're going to make a choice by filling in an additional instructions line, a small minority of people are going to use that line, and so that is a concern. Our group has had significant concerns about the so-called override provision of the bill. I'm not going to get into that at length. And this is the question about treatment over objection, where the form says, right now, the statutory default is that you can't be treated over your objection. I heard Attorney Kate Hanna say, most people think they, don't understand that. Why would they do an advance directive if they didn't want to be treated over their objection? I would agree as to about 80% of my clients, but there's probably about 20% who are very adamant about saying that they do not want to be treated over their objection or have consent to treatment withheld over their objection. In the dialogue we've already had, I think there's already sort of light towards a compromise, and I'm optimistic that one can be reached that both eliminates the burden that provision has imposed, while also, allowing for patient autonomy. So I'm not going to spend any more time on that. The last issue I wanted to focus on was the surrogacy statute in particular, and the question of guardianships. And some of the testimony I've heard at this hearing and in the brief conversations I've had around the bill so far, sort of paints guardianships in this light, like it's this horrible process, to be avoided at all costs. And certainly there's probably some room to streamline the guardianship procedure. And that's obviously a question for the legislature as well. But state law in the guardianship statute has historically provided significant due process protections to an individual who is incapacitated and where there's a proposition that medical decisions will be made by a person not affirmatively chosen by that individual through an advance directive. Prior to the surrogacy statute, that was the only option. The surrogacy provision was introduced as a limited, time-bound means for individuals to have a decision maker appointed when they had not affirmatively appointed one. But even when all family members are in agreement, I would note that the guardianship process requires an individual to be represented by counsel to ensure his or her independent interests are represented. And there's a process by which that counsel is appointed, and state paid in the case of people who do not have funds to pay for counsel. And there's just no similar protection in the surrogacy statute. I understand this complaint that the guardianship process is cumbersome. I would say, having done many guardianships, I'll note the vast majority of uncontested guardianships are pursued without counsel. I think, I don't remember the statistic. I'm sure we could get it from the court system, but at one point it was over 80%. Usually the court schedules a hearing about 3 weeks after the petition is filed and grants the guardianship the same day if there's no dispute from either the a family member or the proposed ward. And with guardianships, the guardian remains under the supervision of the court, can get guidance from the court on the exercise of decision-making, has to report back to the court on at least an annual basis. And there's an existing case open, essentially a forum for other interested persons to weigh in the event that there are any disagreements. And the proposed modifications to the surrogacy statute would do an end run around that guardianship process, allowing for individuals to be appointed for healthcare decision-making purposes with little regulation of their authority and no time limit. Again, I entirely recognize the benefit of the surrogacy statute. The guardianship process is not fast enough in an emergency situation or in a situation, where there's no agent and decisions need to be made in short order. But the point of the 90-day time limit, which was quite hard fought, is my understanding, in 2015, and was an important compromise to ensure that the surrogate's authority, the point of that was to ensure that authority would remain temporary and that surrogacy would not become a de facto relationship for the de facto replacement, for the guardianship process, and the protections that it provides, say long after an individual has been discharged following an acute hospitalization and is in the community with, say, home health care otherwise, and decisions need to be made on an ongoing basis, often with very little supervision. So, it's a concern. I think it's one that hopefully can be addressed through compromise, but it is one that our members thought was very important to identify. With that, I will take any questions that anyone has, and I appreciate your time. Thank you, senators.
Are there questions of Attorney Syracusa? Seeing none. Thank you very much.
Okay, next up is Judith Jones.
Good afternoon, and thanks so much for your time. I am also a member of New Hampshire NALA and speaking in opposition of the bill today, but really struck by and encouraged by the passion of everyone speaking. And I was struck mostly, I listened carefully, and this is one time with the bill, I really see this common goal to understand and honor the patient's wishes. And I'm struck by that can be said succinctly and passionately by everyone. And the work that's been done, I hear the expertise and want to honor that of all the folks who've dedicated time. I think being invited into the stakeholder process, what that does is help someone from my position, meeting client after client, executing documents, but also acting in my life as an agent, understanding the story behind what's happening with the providers and what are the obstacles, understanding that so we can come to a solution to the problem. And that's what I'm looking forward to do, because I hear the problems being raised and know that there must be a way to come to some commonality in how we get there. I wanted to give you a little bit more specific about when we say there's an opposition to the bill, really what are we saying? And I think my colleagues have hit this a little bit. It's the concern that if we have a blank form now, I'm an individual, I'm a patient, I'm going to fill out a form. And the form says, I can set out the limitations of the agent in the form, but that line is blank. Will I know what to put in? Do I know what my choices are? By going through more of options, we have now, I get to decide about life-sustaining treatment, DNR orders, authority of my agent if I voice objection to treatment if the document's activated, which medical providers, doctors, nurse practitioners, physicians assistants may make the decision that I'm permanently unconscious or near death. So it's the concern that if I have a blank line, some of those choices won't be voiced. I won't get the opportunity to think through the questions, and neither would my agent have the opportunity to be educated or understand my wishes. One question is, would hospital staff assisting in filling out the blank line, would they be in the very uncomfortable position of having then to provide advice and a laundry list to patients, where now someone may be able to hear the question, ask for information, circle a choice? Will the hospital staff then have to be in the position to provide details to an individual? Having served as an agent and know the angst of serving as an agent, I can tell you that I was relieved that I had guidance, that I had something in my mother's handwriting that circled a choice to help me carry through. So just a little bit about maybe that aspect of the bill. Also, just looking at the living will, just raising some questions and understand the basis for wanting changes, but just want to say, reading it, I had some immediate questions. For example, if we look at page 16 of the bill, and we're looking at the living will section, it lets an individual elect to have life prolonged, no matter what the burdens, and receive care no matter what the cost or complications. Or in the alternative, the individual may make the election not to prolong life if certain conditions are met by electing the statement, I do not want attempts to prolong my life by medical treatment. And I guess one question is there a reason why the term medical treatment has been used? In the existing form, it's life-sustaining treatment, and that's given a definition. So a dialogue to understand what was the impetus behind that, what was the need for that, and a dialogue about that change, and what are the impacts of that change. Another portion of the living will that I found confusing is, do I meet a condition, one of my criteria? If I elect not to prolong my life, I must meet certain criteria. In one of them, it's I suffer from a condition that will lead to my death. So immediately what I thought was, many of my clients, I say are young, and my definition now of young is someone under age 55, but many of them have a diagnosis of dementia, and we know that that condition can lead to death, but it could last 10 to 12 years. So what is the goal with that language, and what is the purpose of that language? And finally, just wanting to know, how will the healthcare power of attorney and living will work together? And we've heard again that, and appreciate that there's a presumption that the agent's authority overrides the living will. But I guess one question is, if we have a blank line where I have to affirmatively put limits on my agent, and that line is blank, have we put our agents in a difficult position by setting up a conflict without providing them with additional details? So really, in closing, just saying that I'm impressed with this, with all the stakeholders, and see that this is it's not often when I've had to come to testify, it's been so clear everybody has the same goal, and really look forward to an opportunity to try to work through this, and really want to just say how complex these issues are, and just appreciate the honor in the other stakeholders' voices when they talk about the importance of these forms. Thank you.
Thank you very much, Attorney Jones. Seeing no questions, I think we're down to our final two speakers. Is that correct, Jenny? Okie doke.
That's correct. So next up is Bob Dunn.
Hi, Bob.
Good afternoon, Senator Bradley, members of the committee. It's great to see you all again. I hope we're doing this in person sometime soon. I'm Bob Dunn, the Director of Public Policy for the Roman Catholic Diocese of Manchester. We are not taking a position on this bill, but I do have a couple of brief comments to offer, and I've also submitted written testimony to the committee. First off, I want to say that the diocese strongly supports advanced directives. We publish a booklet called 3 Beliefs that is intended to help New Hampshire Catholics execute durable powers of attorney for healthcare. And based on that, we think that Senate Bill 74 makes some really excellent improvements to RSA 137J. And I'd highlight in that regard this new definition of actively dying, the clarification of the precedents of DPOAHs and surrogacy, and the issue of treatment over objection. But there are essentially two aspects of the bill that keep us from being able to affirmatively support the bill as it stands now. And these are laid out in my written comments, so I won't belabor them here. The first one is the definition of post in the bill, which seems a bit broad to us, and that a textual discussion is something that I deal with in the written comments. The second issue is the way that 137J addresses people who are permanently unconscious. And we've heard a reference to this a couple of times so far in the hearing today. We remain troubled by the fact that 137J carves out a separate category for people who are permanently unconscious. And it allows food and water to be withheld from a person who is permanently unconscious, but who is not near death. With that, I will end my testimony and say that I am looking forward to being able to work with this working group, and I appreciate the opportunity to testify. Thank you.
Thank you, Bob. You are a model of brevity. Seeing no questions, Jenny.
Okay, the person that I have signed up last is Rebecca Brown. And then we do have a couple hands raised as well.
Okay, go ahead, Ms. Brown.
Thank you, Senator Bradley and members of the committee. Can you all hear me okay?
Yep.
Great, thank you. So I'm representing a new citizens group called the New Hampshire Alliance for End of Life Options. And we are a new grassroots citizens advocacy effort aimed at improving access to quality, patient-centered healthcare for all New Hampshire citizens, particularly at the end of life. And because of our focus on the end of life, we're pleased to introduce ourselves to you in the context of this bill. We support legislative changes that will make end-of-life planning available for more people, that will make the process and the forms more understandable and easy to complete, that will make our advance directives reciprocal with other states, and that help individuals and their loved ones understand what the directives do and don't do. The last thing people need in time of medical crisis is to struggle to have their loved ones' wishes understood and respected. We believe that patient wishes and choices must be understood and respected, whether they are for more treatment or for less. We also believe that people need to understand more fully their medical options, their rights as patients, and the consequences of treatments or of not treating. We want to encourage anything that can help that process, including using the tools of advance directive and the PULSE. Issues around death and dying bring up the most fundamental questions we face as humans. They challenge us emotionally, ethically, and spiritually, as well as legally. We support a process in addressing today's legislative proposal to make sure that these very complex issues are given ample time, attention to detail, understanding the consequences, and include the input and agreement from a diversity of people and interests. So thank you. And as a former state representative, it's nice to be virtually with you today. I appreciate the opportunity.
Thank you very much, Representative Brown. Seeing no questions. Okay, Jenny said that there were a couple of hands raised, so I would ask if you've already testified once, maybe to think about not testifying a second time. You're going to have the opportunity to work with Senator Sherman. So if there are people that had not signed up and want to testify first time, go ahead, Jenny.
So the first one, their name is just Therese, I think. Not sure. If you could unmute yourself and then just identify yourself for the record, please.
Yes, Therese Stokes, New Futures. I just wanted to make a comment about Colleen statement regarding the withholding of nutrition and hydration. My brother passed away in December, and I watched him go through that. And everything that she talked about, the no water with the lips and the sugar with the dry throat and the electrolytes with the leg cramps, and everything she described was absolutely dead on. And it was a horrible, horrible thing to watch. And I would like everyone to please consider that as part of the bill, because that is something that I would never want to see again. So please consider that. Thank you.
Thank you very much, ma'am.
Okay, next up we have Frederick Rice.
Hello, can you hear me?
Yep.
Sweet.
Thank you, Honorable Chairman and Committee, for hearing my testimony, despite the fact that this was scheduled to be 15 minutes in length. I am Frederick Rice. I live in Hillsborough, District 12. I am testifying in support of SB 74. I am speaking to you today as a person who has an advanced medical directive and who is listed in others' advanced medical directives. The clinical trials and experimental treatments exemption to an agent's power in New Hampshire blew my mind. This was totally counter to my desires and to the desires of others whose advanced medical directives I'm listed on. I'm really happy to see that in this legislation, and I fully support it. Yeah, that's all I had to say. Thank you.
Okay, thank you, sir.
So Senator Kate Hanna has her hand still raised.
Very, very briefly.
If that is referring to me, Kate Hanna?
Yes.
I did not
Yes,
have
it
my,
is.
okay, I did not have my hand raised. I'm sorry.
Well, that was brief. Thank you very much.
All right, Senator, that's it.
Okay, so Senator Sherman has made it very clear that he's going to convene a working group of all of the interested parties. I think, and I suspect that other members of the committee share my view that the issues raised are complex, but they hopefully can be resolved. We do have, it's hard to believe that we're in such an early part of the session, but we're already talking about deadlines. So for everybody that is interested in this bill, and I think everybody has testified about the need for it, whether they're supporting the exact provisions or not. Basically, you have, till the middle of March to try to work out the details. So Senator Sherman, have at it. You've got a lot of work ahead of you. But I think, Zoom is good for something. So there'll be a lot of Zoom meetings on this subject. Okay. And any other member of the committee, as long as it's not a majority of the members, can work with Senator Sherman to do it, as long as it's not a quorum. Okay. Okay, I will close the hearing on Senate Bill 74. And let's open the hearing. Or does anybody want to take a 2-minute break? Then we'll open the hearing on Senate Bill 75 and recognize the prime sponsor, Senator Prentice.
Thank you. Good afternoon, Chairman Bradley. And members of the Health and Human Services Committee. For the record, my name is Suzanne Prentice, State Senator for District 5, proudly representing the cities of Claremont and Lebanon and the towns of Cornish, Charlestown, Hanover, Enfield, Canaan, Lyme, and Plainfield. I'm here to introduce Senate Bill 75 relative to school district information on the COVID-19 dashboard maintained by the Department of Health and Human Services. As you all know, on March 13th, 2020, Governor Christopher Sununu signed the first declaration of a state of emergency due to COVID-19. To date, this order has been extended 15 times. When COVID-19 effectively shut down our schools last year, we all knew there would be a time and plans to reopen. The decision making around how and when to reopen would be and should be driven by data, including evidence of COVID-19 community transmission. As the COVID dashboard has evolved, data for the schools has its own section on the dashboard. Active cases within the schools are reported in the school section of the dashboard for when that school or even part of that school is in person, including hybrid, specifically the times when an infected individual has been on school property and has had contact with others. However, if the school is in remote status and one or more of the students, faculty, or staff test positive that are not on site at the school, that data is not reported on the school dashboard, but is reported as part of community transmission. I've been approached by parents and school board members that have concerns that the number of active cases in the school section of the dashboard does not account for the entire school community by policy when on remote status. It would be beneficial to the decision makers, the parents, and the public to see the overall picture of their school community in one place. I do want to be clear that decision makers do need and should consult the overall community transmission as part of their decision-making process when deciding on how and when a school will be operated in what status. I also want to clarify that not all schools report to the state. Some maintain their own dashboards. Well, with that being said, Senate Bill 75 seeks to rectify this by requiring that the overall school community data be included in the education / I call it school specific dashboard. Over the past 2 weeks, I've had the pleasure of working with both David Whiters from the Department of Health and Human Services and Christine Brennan from the Department of Education on this issue. We know that we have the data needed to provide this type of overall school community information in the school section of the COVID-19 dashboard, and we are working together towards a resolution. Respectfully, I would ask that the committee not exec Senate Bill 75 at this time and allow me to continue to work with our state partners towards a resolution that I believe is underway and in earnest. Thank you. I'm happy to take any questions that you might have.
Are there questions of Senator Prentice? Yes, Senator Woodley.
Thank you, Mr. Chair, and thank you, Senator Prentice, for bringing this bill up. I will say in my communities, I have heard similar issues about how important accurate data is to making these big decisions. And I'm wondering, what you've heard in the communities in terms of sort of a lack of state guidance for these communities. In particular, we know our school boards are made up of community members, and they are being asked to make very, very significant decisions that impact their community and children. And as a mother, they impact me, right? When my children's school is closed, I have to support him with remote learning with my family. So I'm wondering what you've heard with communities about the impact of an updated dashboard on these very difficult decisions.
Thank you, Senator Whitley. So it becomes almost two separate issues. When I've talked to, again, the Department of Education and worked through what we call the absenteeism reporting form that those who are using, schools that are using the COVID-19 dashboard, there's a very specific set of guidance in there and a way, to standardly report. I think the issue becomes that some districts are maintaining, some schools and school districts may be maintaining their own dashboard. And with that comes the concern about a lack of guidance. I've been assured by the Department of Education that, there have been these conversations as well as Health and Human Services. We could certainly go further and have a commitment to do that, but the disconnect is really the fact that, and this is through a learning process, that this information is almost housed in two different places. So that's, I think, if you're housing your own dashboard, that's where you're looking for more guidance. But those that are reporting up through the state system have a very clear, they have a very clear form that they fill out. And we also know that this is added work on top of what schools are already, school nurses, school administrators are already doing, but we all recognize that it's necessary and important for these big decisions. So I don't know if that completely answers your question. I've learned what the difference is between these and why I think there is some, I don't want to call it confusion, but unsettledness around the issue.
It does. Thank you, Senator Prentice.
Further questions of Senator Prentice? So I would just say, Senator Prentice, I appreciate that you reached out to me. We will not take any action on this bill today. I think that you are correct in your assessment. If this can be worked out on a collaborative basis with the departments and yourself and have a non-legislative solution, that would probably be the best solution because this process is, as you know, fairly cumbersome by the time all's said and done. So I would just say that. Any other questions for Senator Prentice? Seeing none. Thank you. Jenny.
Next up, we have David Wieters.
Good afternoon, sir.
Thank you very much, Chairman and members of the committee. I appreciate the opportunity to speak on Senate Bill 75. My name is David Wieters. I'm the Information Services Director for Health and Human Services, and the primary, I would say, project manager for the COVID-19 schools dashboards. So I would echo Senator Prentice's comments that we are eager to work with her to move forward to address this concern that has been in the community regarding the dashboards and the communications in which our current dashboards provide. Just to be clear, our current, we look at it as two different perspectives, and we want to address both of them. The first perspective is that students that are actually physically attending school activities or going to school that are diagnosed with COVID-19 are at a higher risk of transmitting that virus to others in the school. And so that's what our current dashboards really depict. However, through the conversations with Senator Prentice and conversations with members of Department of Education and schools and school nurses, we certainly understand the concern and the need for having a community, like a school community population information on that same dashboard so you can see it from both perspectives. So just to close, we are eager and we're already working on addressing those needs, and we anticipate being able to meet that expectation in the upcoming weeks.
Very good. Are there questions of Mr. Wieters? Very good. Thank you. Jenny.
Next up, we have Christine Brennan.
Good afternoon, Ms. Brennan.
Hello, how are you? Christine Brennan, Deputy Commissioner from the Department of Education. And really, I am here as a resource if you needed me for any questions. And so I think that Senator Prentice really laid out what the issues were, and it's been a pleasure working and the Department of Health and Human Services on the COVID dashboard. So thank you.
Okay, are there any questions of Ms. Brennan and the Department of Education? Very good, seeing none.
So Senator, the last person we had signed up was Frederick Rice, but he appears to no longer be here. So I have no one else to sign up to speak.
Okay, so is there anyone on Senate Bill 75 that did not sign up to speak but now wishes to speak?
It looks like Brian Hawkins has his hand raised.
Okay, good afternoon, Brian.
Good afternoon, Mr. Chairman. Thank you for the time to speak. I hadn't planned on speaking originally, but I did want to offer just a couple of comments. First, we support the bill and support Senator Prentice's efforts to bring parties together to try and work through some of these data issues in a non-legislative fashion, if that's possible. One of the concerns that I've heard from some of our members is sort of the level of guidance too that it's given to schools with respect to how they report whether a COVID case is in their school or not. One thing that I have heard that is concerning is if a student doesn't test positive that day that they're in school, then that is not counted. And I'm not saying all school districts do this, but it is a concern I have heard brought up a number of times. And obviously we know that the period of time with which COVID can be transmissible happens several days prior to that test. So I think in terms of, as Senator Prentice mentioned, having the right data to make the right decisions so that communities are fully aware of the situation, having a sort of uniform, fully communicated standard by which COVID-19 positive cases are submitted would be really helpful. And if we can do that, Obviously, legislatively would be fine, but I know we can do this much quicker if it can be done, as Senator Prentice said, by working with the departments. I'll close my testimony. Happy to take any questions.
Thank you, Brian. Seeing no questions, thank you very much. Anyone else? Okay, in that case, I'm going to close the hearing on Senate Bill 75, and I would entertain a motion to go into executive session.
So moved.
Moved by Senator Whitley, seconded by Senator Sherman. I will call the roll. Senator Whitley?
Yes.
Senator Sherman?
Yep.
Senator Gray?
Yes.
We hadn't heard from you all afternoon, James.
Been quiet, listening.
I know. And I vote yes. So we're in executive session. I think we can take action on two bills. Senator Sherman's bill, Senate Bill 59, and Senator Gaida's bill, Senate Bill 45. So Griffin.
Yes.
Can you put up the amendments that we have on the screen?
I'll do. What bill do you want me to start with?
You can make the choice of which bill, whatever you have in front of you.
I'll go with Senate Bill 45. Give me 1 second here. Can you all see that?
Yep.
Yep, so we should be looking at Amendment 28. Amendment 28, as I recall, just replaced much of the bill with, I think it was eliminating everything except Section 3 and 4. So if you look at the bill that Senator Gaida introduced, it had Section 1 and Section 2. One was a statement of intent. And then the second one was the whole discussion about confidentiality. And then Sections 3 and 4 are what is in the amendment, and then Section 5 is become Section 3 and Section 4. So the big controversy in the bill, as everybody remembers last week, was use of the data. I did hear from John Williams that the department is ready to proceed with Senator Gaida's amendment. I didn't talk to John. I was just copied or texted by, I think it was you, Griffin, that the department was ready to proceed.
May I ask you a question?
Yes.
So does this get rid of the data sharing with the department for now?
This is your amendment with
Right.
Senator Gaida and
Oh,
Senator
so this is the
Rosenwald.
same one. This isn't new. This is the
This
one
is
that
not
we
the
had.
new amendment.
Oh, okay.
I had a long explanation to try to explain what the amendment did vis-a-vis the bill, and also indicate that the department was okay with it. And there may be some discussion about the confidentiality in the budget phase, but we'll have to see what happens. But they're ready to move forward with your amendment, Senator Sherman.
Okay, so I'm sorry, I didn't realize this was, actually Bob Gaida is calling me on the phone right now, but I didn't accept. So I believe that this is the amendment that Senator Rosenwald, Senator Gaida, and I put together. I'm sorry, I didn't.
Well, that's what I'm hoping to get a ought to pass motion on.
Right. No, I'm fine with this. So I'll move ought to pass.
Second.
All right, so it's been moved on to pass by Senator Sherman, seconded by Senator Whitley. Is there any further discussion? Seeing none.
Move
Senator
on to
Gray.
pass the amendment.
Senator Gray?
We need to move ought to pass on the amendment.
That's what the motion is.
I heard on the bill. That's what I had heard. I could be misunderstood, but as long as.
Well, the motion, I made the motion, so I will make the motion ought to pass on the amendment.
I second that.
All right, Jenny, is that the protocol you want?
Yes, that's
Okay.
perfect. So we have a motion on the amendment and we just need to take a roll call vote now on that.
Okay, that's what I thought. Okay, so Senator Gray,
Yes.
Senator Sherman,
Yes.
Senator Whitley,
Yes.
and I vote yes. Okay, so the amendment 0028 passed 4-0. Is there now a subsequent motion on Senate Bill 45 as amended?
So moved.
So it was moved by Senator Whitley, seconded by Senator Sherman. Is there any discussion? Seeing none. Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Sherman,
Yep.
and I vote yes. So obviously Senator Avard not being here can't go on consent.
Let's make him take it out.
Yeah, make somebody who's not here take it out who didn't vote.
Yeah, because we're going to have, my understanding is we will now have to have 2 roll calls, one on the amendment and one on ought to pass as amended. But be that as it may, that's what we'll have to do.
I'm happy to take it out if you like.
Okay, Senator Sherman will take out Senate Bill 45. All right. I believe based on the testimony that we can take up Senate Bill 59. And I think there should be a motion on Senator Sherman's amendment 0133. Senator Sherman?
Yeah, sure.
All right, so the Griffin has put the amendment up. This is the amendment that was distributed to everybody. Senator Sherman has moved it. The testimony on all sides was that they were in favor of it. I think the insurance department had some questions about whether it's a mandate. I think we heard the testimony of Anthem that it's unlikely to be considered a mandate. So in my view, I think we can go forward with it. It is, I think by all accounts, a way to have better care and cost saving. So any further discussion on Senator Sherman's amendment?
Yeah, and I would agree on that mandate issue. If you look at, the essential health benefits, there's another argument to be made that this is just, clarifying a certain model within an existing covered benefit. So, assuming all the parties okay with this amendment, I don't know if we got a second on that, actually, Chairman.
I think you're the second.
There we go.
I don't believe anyone's made a motion yet.
Senator Sherman moved ought to pass, and now it's been seconded by Senator Whitley.
Yes.
I got to discussion faster than the second, sorry. All right, any further discussion? Seeing none. Senator Gray,
Yes.
Senator Sherman,
Yes.
Senator Whitley,
Yes.
and I vote yes on the amendment. Is there a motion of ought to pass as amended on Senate Bill 59?
So moved.
Moved by Senator Whitley, seconded by Senator Sherman. All in favor, I will call the roll. Senator Gray,
Yes.
Senator Sherman,
Yes.
Senator Whitley,
Yes.
and I'll vote yes also.
Well, I guess I'll take that out too.
All right, since it's your bill, I guess you get to do the honors on that one. Okay, the third bill that we have two other bills, three other bills. Hopefully Senator Prentice can come to a non-legislative solution on her bill. And we can find it inexpedient to legislate. We'll have to wait on that. On Senate Bill 29, where we had a hearing last week, that was Senator Guida's bill on lower dosage, lower THC content for marijuana for underage people. That the Advisory Council for Therapeutic Cannabis is going to meet and discuss it. So we'll wait for that. And then obviously Senator Sherman's bill, Senate Bill 74, I think that'll take some time. So 3 of the 6 bills that we've had, we've taken action on at this point. I think next week we have our first omnibus bill sponsored by Senator Hennessy. It's a pharmacy related bill. And Griffin, what was the second bill?
Second bill is, I believe, Senator Whitley's bill on SNAP incentive program, I believe.
That's right. Yep. Okay. So those are the only 2 bills that we had been assigned as of yesterday, which means the close of this calendar. So
Are we next Wednesday morning? Is
I
that
believe
right?
that's our time slot, Wednesday morning.
Okay.
Okay. Is there anything else to come before the committee?
Just a motion to come out of exec.
Seconded by Senator Gray. All in favor, Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Sherman,
Yes.
and I vote yes. And now a motion to adjourn.
So moved.
Senator Whitley moves, Senator Sherman seconds. Senator Gray,
Yes.
Senator Whitley,
Yes.
Senator Sherman,
Yep.
and I vote yes. Are we good to go, Jenny?
And the snowplows came by while so I've got things to do outside.
We are good to go.
All right, Jim. Okay, thank you all very much. See you next week.
Thank you.